when you work up the patient, it's important to know that a weight-bearing film should be done. Here's a film of a foot and a patient with a flat foot that looks perfectly normal. The talus first metatarsal angle is normal because the patient wasn't really putting his weight on the film. Here's the same patient with a little bit more weight, and here's the same patient with a fully weight-bearing film. So unless these films are done weight-bearing and unless the CTs are done weight-bearing, we really can't get a good idea of what the problem is. The same applies on a lateral, where the talometatarsal angle goes from completely normal to completely abnormal with weight-bearing. I like to use weight-bearing CTs to help me define these as well. I know that this is not a widely used technique, but it helps us see things that can't be seen by a plain film. So here's a sagittal reconstruction of a relatively bland flat foot. You can see how severely inclined the talus is relative to the first metatarsal, and you can see this very dramatic subluxation of the cuneiform metatarsal joint. As well, on the sagittal reconstruction, if you look at the bottom corner, you can see that the sinus tarsi is completely closed down. So the calcaneus is very everted. It's closing down the sinus tarsi. And on the coronal cuts, you can see the true peritalar subluxation that we talked about a little while ago. So here's the talus, here's the middle facet, and you can see that the middle facet of the calcaneus is drifted lateral relative to that of the talus. So this is a peritalar subluxation. This is the same patient with a relatively mild looking X-ray and a relatively mild CT, but still showing about 50% subluxation of the middle facet. So we know that flat foot is defined as an abnormal position of the bones, and we know that it's pretty common. About 10 to 30% of adults have flat foot as defined by arch parameters. There's some data in the British literature that's not been supported by other documents, but there's a suggestion that if children wear shoes when they're young, they're more likely to develop a flat foot than if they go barefoot when they're young. This is the only paper that I know of to come to that conclusion, but it's an interesting idea since there's substantial literature trying to support the use of orthotics in children. I think there's really no foundation for that, for using orthotics in a child with a flat foot. So we talked about the importance of a tight heel cord in the assessment, and it's important that the heel cord be assessed with the talonavicular joint in the neutral position. This is a diagram out of Luc Bordelon's book, in which he puts his thumb right at the talonavicular joint to make sure that it's positioned properly, as it's done here, before the exam, to make sure that you're not fooling yourself into thinking the heel cord's not tight. So here's a patient who has the leg straight, the foot almost perpendicular to it, and you could almost convince yourself that this is not a tight heel cord. But if you examine the patient, you see a lot of motion. Let me just run that again. You can see that it seems to dorsiflex completely into a neutral position, but a lot of that change is coming through the midfoot. Now if you take that same patient and lock the talonavicular joint with a thumb, thereby restoring the nice arch that you can see here, and then try to examine the same exam. Here's with the knee bent, and here's with the knee straight and attempted dorsiflexion. You can see that there's about a fixed 20 degrees of equinus, even though the foot looked completely neutral without locking that joint. I'm going to run that clip again. You can see when the knee is bent, it comes up, but when the knee is straight, you're fixed in 20 degrees of equinus, indicating that all of that tightness is in the gastrocnemius, not in the triceps. So it's nice if it's all in the gastroc, because then you can release the gastroc only and not have to worry about casting in the postoperative period. When Steve Pinney was here as a fellow, he took this little toy we developed called the equinometer to measure equinus in a large number of patients who had tight heel cords. And he measured them before release of the gastroc and measured them after the release of the gastroc. And to no one's great surprise, found out that there's nearly a perfect correlation between the amount of dorsiflexion you can obtain with the knee bent preoperatively and the amount of dorsiflexion you can obtain postoperatively after a gastroc release with the knee straight. So essentially, the equinometer can predict how much correction you can get. So if you measure the amount of dorsiflexion they have and it doesn't come up enough with the knee bent, then you probably need to do a tendo-Achilles lengthening rather than a gastrocnemius release. So interestingly, there's been a lot of talk lately about arthritis of the ankle, and we found accidentally in the review of one of our fellows a couple years ago, And looking at 435 patients with ankle arthritis, if you eliminate the patients who've had a fracture of the joint, eliminate the patients who've had an inflammatory arthritis, and just look at the patients who are so-called osteoarthritis of the ankle, you found that almost all of those patients had either a cavus or a flat foot. So not surprisingly from mechanically oriented people, but if the foot is tilted, the ankle wears out. So there's one more reason to think about treating this problem before people get to the end-stage arthritis position. So about 10 years ago, we tried to figure out, is an acquired flat foot acquired because the bones change shape or because the position of the bones change shape? It's kind of a horse and carriage or a chicken and egg phenomenon. What causes it to be flat? So to try to answer that, we again looked at some three-dimensional models. So here is a calcaneus, here's a talus CT scan, here's the middle facet, as you can see clearly subluxed. So you can draw a line along the middle facet of the calcaneus, draw a line along the middle facet of the talus, and you can abstract that line alone into its own field. And then you can stack these lines into a software product that'll create a surface map. And we compared a group of patients with symptomatic flat feet to a group of patients age-matched without symptomatic flat feet, and this is the map that we created. So in blue is the talus surface, middle facet and anterior facet on this side, and in red is the calcaneus and posterior facet. And so here's posterior facet, calcaneus in blue and talus in red. Here's middle and anterior facet, same color scheme, of a normal patient with a normal foot. Here's that same surface map of a patient with flat foot disease, and you can see that instead of the talus being on top of the calcaneus has drifted posteriorly and laterally relative to the talus. So this is true subluxation of the subtalar joint. So the answer must be that there's subluxation causing the problem rather than joint morphology. But just to make sure, we also looked at the opposite problem, and we're not the only ones. Deland and Dial looked at radiographs of flat feet in non-symptomatic patients and compared them to patients who are symptomatic and found that there was really no difference in the radiographic parameters. So there's some other issue other than radiographic parameters in bone shape. So we took it a step farther and looked at the three-dimensional shape of the bone by using the same surface map technology and compared the shape of some of the hindfoot bones. And we found that, in fact, there is a difference between painful flat foot surface morphology in that the talus is significantly wider and the body is less high. But then when we compared non-symptomatic talus flat feet to symptomatic talus flat feet, we found that there was no difference. So there's some shape abnormality that predisposes a person to have a painful flat foot. But some people go on to painful flat foot and some people don't. So we know that it's a combination of abnormal shape and abnormal position, but there are some other mysterious factors that we can't calculate quite as well. Why does it hurt? We know that some of them hurt because the posterior tibial tendon is inflamed, some other issues. If you take these same three-dimensional CAT scans or weight-bearing CAT scans and you look, you see not only abnormal arthritic conditions, but also abnormal impingement. So here's the calcaneus, talus, fibula, and tibia. And you can see that the calcaneus is completely eroding into the fibula. I don't know where the peroneal tendons are. They should be in that space. You can also see that the sinus tarsi is completely collapsed. There's actually arthritic conditions where there shouldn't be a joint in the first place. So here's a three-dimensional model of a flat foot. This is on the top, talus. We're looking at the front of the talus and the front of the calcaneus. And here's looking from behind. Again, at talus, we've made the calcaneus see-through, so you can see that the entire border of the foot is moving laterally. As the calcaneus drifts laterally, the cuboid follows it, and the whole forefoot does as well. And you can see this is a CT scan, a weight-bearing CT scan of a patient with symptomatic flat foot. You can see that the calcaneus is eroding into the fibula. The talus is no longer covered, and the talar head is plantar flexing. If you look at that same patient after lateral column lengthening, the space is recreated beneath the fibula. You can still see the eroded area. And the talus is now supported by the sustentaculum tali, and the lateral border of the foot is completely straight again. So it's analogous to these plastic models. You can see as the medial part of the arch collapses, from normal to collapse. There's a gapping of all the joints, and as you look to the back, the calcaneus goes from this normal position to this abducted position. A little video clip is surprisingly similar to what we see in the real world. So as you push down on this plastic articulated model, it opens up in the same way that the CT scan we just showed did. And if you look at that same articulated model from behind on the lower clip, you see how the calcaneus translates laterally and into the fibula. And if you compare that to a weight-bearing CT model, it's very, very close. It's a very close simulation. So this seems to be simply a matter of gliding along the normal axis of the joints. So what does this all mean? It means that there are a lot of things that lead to painful flat foot. The shape of the bones is a problem, the spacing of the bones is a problem, and the treatment really needs to be geared toward whatever that problem is that has resulted in this end-stage flat foot. There's no single treatment that works. So the treatment options are bracing, soft tissue balancing, osteotomy of the bone, and arthrodesis of the bone. In terms of non-surgical treatments, I think the simplest is the University of California biomechanics type orthosis. This orthosis captures the heel, it inverts it slightly, that allows the midfoot joints to lock, and it corrects some of that subtalar dislocation. It also gets the calcaneus more in line with the underside of the talus. It's not a very good long-term solution, but it's a good solution for patients who have medical comorbidities or some reason why surgical intervention is not good. If you have someone with a more severe problem who also is a not surgical candidate, an Arizona brace, which is a custom leather lace-up brace, is an alternative. It's essentially like wearing a very high boot or a custom-made cast for the rest of your life, but for some patients it's an adequate therapy. The surgical treatment's a little bit more complicated. The only thing you can say almost for certain is that either the gastrocnemius or the triceps need to be released. The rest of the problems have to be individualized to whatever is found. So flexor digitorum longus is the most common soft tissue procedure performed. That can be put into the cuneiform as shown in this diagram. If you use this approach, it does allow a little bit of undersurface support for the talonavicular and navicular cuneiform joints. It can also be weaved directly into the posterior tibial tendon as it's shown here, with the ankle up at this end and the toes down at this end of your screen, if the posterior tibial tendon is sufficiently healthy. A medial column fusion or arthrodesis is good for those patients who have a midfoot sag with very limited forefoot abduction and only small amount of hindfoot valgus. Can be a corrective arthrodesis through any of the midfoot joints. There isn't a lot of outcome information on this study, and it's been around since at least 1931. So this is a poor quality diagram out of an article from that original article, and you can see that a trough is just made in the medial part of the foot, and the bone graft was just placed into this position. This was long before the days of rigid internal fixation. This is a great quote from Miller's article in 1927. There can be no dogmatic classification of so-called flat foot. Treatment should be geared toward its discomfort, ugliness, and the end result that you expect. And practically always the heel cord is pathologically shortened. So that hasn't changed much, but the technique has changed a lot. He just used a strip of bone or a piece of tibia. Now we tend to do something a little bit more thoughtful in that we can hold the position of the bones with internal fixation. So this is a perfect candidate patient for a Miller procedure. You can see that there's a sag at the metatarsal cuneiform joint in this area, and the Meary's angle is abnormal, but there's not a huge amount of closing down of the sinus tarsi, just a moderate amount of closure, and only a small amount of abduction.